All right, thank you everyone for joining us today for this webinar. My name's Laura Katawaki, and I'm a Research and Knowledge Mobilization Specialist at United Way BC. I'm really excited today that we're going to have the opportunity to learn more about two key programs that are helping to support older people to age in their communities. And these programs are the Nav-CARE program and then the social prescribing program with our community connectors at United Way BC. So today our webinar is going to focus on supporting communities together, exploring Nav-CARE volunteers, and community connectors in action. Before we begin the webinar, I'd like to do a land acknowledgement. So United Way acknowledges the homelands of the Indigenous peoples of this place we now call Canada and honors the many territorial keepers of the lands on which we work. I today am working from home, and so I'm calling in from the traditional, ancestral, and unceded territories of the Coquitlam First Nation. I also just want to acknowledge that, of course, next week on Tuesday is going to be the National Day for Truth and Reconciliation. And so I would encourage all of us to think about how we can reflect upon Canada's history and the history of the Indigenous people, and to reflect also on, of course, the Truth and Reconciliation Commission. And I'll put in the chat later on some resources that might be helpful if you're interested in learning more about the Truth and Reconciliation Commission and also about the Indigenous peoples in Canada. A few housekeeping notes for the webinar. So during the webinar, all the attendees will be muted. Feel free, though, to introduce yourself in the chat box if you'd like. You can put in your name, pronouns, organization, or territories you're calling from, whatever you want to share. If you would like to use the closed captioning feature, you can press the CC button at the bottom of your toolbar, and that should turn on closed captioning. For this webinar structure, we're going to be hearing some presentations about Nav-CARE and the social prescribing program. And then we're going to be hearing actually from some of the people who are implementing the programs on the ground. And then we'll have time for a question period. If you'd like to put in any questions, feel free to put them in the Q&A box, or you can put them in the chat. And then finally, I just want to note that the webinar is going to be recorded and it'll be posted on Healthy Aging Core. And so we'll send you an email with the recording and also the slides. All right, so I'd like to start by introducing our presenters. So to begin the webinar, we're going to hear from two presenters who will be talking about the different Nav-CARE and Community Connector social prescribing programs so that we can learn more about the basics. And so these presenters are Dr. Barbara Pessett, who is a professor in the School of Nursing at the University of British Columbia, Okanagan. She was the original developer of the Nav-CARE program, along with Dr. Wendy Duggleby at the University of Alberta. And Nav-CARE has been in development for over a decade and has been scaled out across Canada and Europe. And then we're also going to be hearing from Prab Sandhu, who is the Healthcare System and Community Specialist on the Healthy Aging team at United Way BC, where she leads the province's social prescribing work. In her role, Prab focuses on integrating social prescribing within BC's health landscape, and she has facilitated key discussions and meetings with the health authorities and contributed to the development of the social prescribing implementation guide and the orientation training for community connectors. We also will be hearing later on from two presenters who are going to talk more about the on-the-ground realities of implementing the social prescribing and Nav-CARE programs. So we'll be hearing from Yola Switowski, sorry, hope I pronounced that right. Yola has worked as a community connector for 3 years at North Shore Community Resources in North Vancouver. And she's also pursuing a master's degree at UBC, studying care navigation, social prescribing, and dementia. And then we'll also hear from Nicole Tate from Brella Community Services Society. And she's the Director of Community Services at Brella Community Services Society, where she leads initiatives that support and empower older adults in the community. And with a strong commitment to equity, inclusion, and collaboration, she works to ensure that programs meet the diverse needs of vulnerable seniors and their caregivers. And Nicole brings passion and experience to fostering meaningful connections and building supportive community networks. And Brella actually has both the social prescribing or community connector program, as it's known, and also the Nav-CARE program. So she'll be able to speak to both of those. All right, and so now that I have introduced the presenters, I'm going to stop the screen share and I'm going to ask Barb and Prab to join me so that we can talk a little bit about the Nav-CARE program and also social prescribing, which sometimes is also known as community connectors. All right, so Barb and Prab, thank you very much for joining us today. I have a few questions that I'm going to ask you so that I hope we can provide some more details to the webinar attendees so that they can learn a little bit more about these programs in terms of what they are and also learn about the differences and how they can complement and support each other in communities. So the first question that I have is just a very basic one. So I'll start off with Barb, if you'd like to go first. Can you tell us about the background to your program and its overall goals?
You bet. Thank you so much, Laura, for the introduction and for hosting us today. And thank you to all of you for joining us. You know, Nav-CARE, as Laura mentioned, started over a decade ago. And it really began with research in rural communities at end of life. And so I was traveling around rural communities in BC and interviewing all the different people involved in palliative care, including families, healthcare providers, and three things really struck me. One is that healthcare providers consistently went above and beyond to care for people at end of life. Second was that these communities just wrapped around people in an incredibly compassionate way. And third was that volunteers contributed an amazing amount of care at the end of life and that they were incredibly skilled in what they were doing, but weren't always being used to scope. So based upon that, we got some funding from the Peter Wall Foundation and trialed a nurse navigator for rural palliative care. And she cared for people for 2 years in community, and we saw some just amazing results. You know, people made better decisions, they got more connected, they were less likely to use the emergency department. And so there was just a really good outcome from that. But as you can imagine, it's very expensive to employ a nurse to do navigation for each rural community. So from there, we partnered the nurse with some volunteers, did a similar type of model, and just again had incredibly good outcomes. So since that time, we've been developing and refining the model over time. And so let me tell you what Nav-CARE is. Nav-CARE stands for, of course, navigation. And then CARE stands for connecting, advocating, resourcing, and engaging. So those are the four functions of the volunteer, really important part of their competency development and role. And so what we do is we recruit volunteers through community-based organizations. They get additional training in Nav-CARE, and then we partner them one-on-one with persons living with declining health in the community, and they visit on a regular basis. And really the goal of the program is to keep people at home for as long as possible, but not just to keep them at home, but to keep them at home with a good quality of life so that they feel well connected to their communities and to other people, and so that they really have access to the resources that they need.
Yeah, thank you very much for sharing that background about the program. I can definitely see already some of the ways that it complements with the social prescribing initiative that we have at United Way. Prab, would you be able to tell us more about social prescribing?
Yeah, of course. Thank you, Laura. So, as Laura mentioned, I work with the Healthy Aging team at United Way BC. And our focus is on supporting older adults who are living with low to moderate frailty, who often fall into what we call our priority population. So these might be individuals who are at greater risk for social isolation, maybe food insecurity. They might be facing barriers due to language, culture, systemic inequities. So the community connector role is central to our social prescribing program that Laura mentioned. So the connectors are based in local agencies. They work alongside older adults to identify what matters the most to them. They link them to the supports and services that can improve their well-being. But beyond that one-on-one support, the connectors also invest in building stronger community networks. So that means bridging healthcare, local government, community-based organizations. Um, and they create pathways of support that are more connected and accessible for, it could be everybody in the community, but also just around some of the seniors that they support. And so that kind of circle of support around that senior is wrap around and they're well connected to all the resources that are available to them.
Yeah, thank you for that introduction, Prab, to social prescribing. And I'm wondering if you could provide a little bit more detail now about how the social prescribing program is actually delivered in community. You've touched on a little bit of that, but would you be able to provide some more details?
Sure. So the social prescribing program is designed to stay close to the people it serves. But it's a layered approach. At the provincial level, the Ministry of Health funds all of our healthy aging programs in BC, social prescribing being one of them. And a very important one because that one bridges the healthcare system with the community supports. United Way BC manages the distribution of those funds, and we provide a backbone support like training, resources, spaces for connectors to share learning, so that the program is consistent throughout the province while still maintaining that flexibility and adaptability enough to fit each community. So local agencies hire the community connectors. And what matters here is that the community connectors are part of the communities that they serve. So they're based in organizations that already have strong relationships with the older adults in their communities, maybe. And this sort of, this makes it so that they have an easier trust or an easier way to build trust and create meaningful connections. And then in practice, what the community connectors do is that they meet with the older adults who are referred to the program. They take time to understand what matters most to them. And then they work with them to develop a wellness plan. And sometimes that includes warm referrals. For example, if a connector helps someone sign up for maybe a senior swim class, they might even go with them to that first class to ease that transition. So the goal is to empower older adults and equip them with the tools and information and ongoing support that they need to stay connected with their communities and access the supports that make a difference in their daily lives. At the same time, connectors also work behind the scenes to strengthen the local networks between healthcare, social services, and community groups so that the system feels easier to navigate for everyone.
Thanks, Prab, for those details. Barb, would you be able to provide a bit more information about how the Nav-CARE program is actually being delivered in communities?
You bet. So Nav-CARE is always delivered through community-based organizations. And so our organizations traditionally have been hospice. And our organizational model is really, really important because even though we're researchers at UBC and a team, it's really those on the ground organizations that have the expertise and the accountability to really help mentor volunteers and make sure that they work within a framework of policies and procedures. So hospice societies are often our organizations, but really any organization that works with volunteers in the community can be a good organizational fit for a Nav-CARE program. And what we've done with some communities in past is say they have a volunteer driver program. So they may take those volunteers and give them Nav-CARE training so that they really enhance their role within a currently existing role. So we work with all kinds of community-based organizations. And just as Prab said, it's really important to recognize that Nav-CARE can actually be adapted to that community organization. So when I talk about Nav-CARE today, I'm kind of talking about Nav-CARE in the ideal sense in terms of how we developed it. But as you see it roll out across Canada, you'll see quite different variations of the program depending upon that community-based organization and what their particular needs are. But I would think it's safe to say overall that really the focus within these community organizations is to really focus on and adapt the scope and the role of the volunteer. I think what we've known across Canada forever now is that we have this amazing resource of volunteers, but we often have difficulty maximizing their scope of what they're capable and doing that idea of connecting them to the people that really need them. So that's a big part of the focus. The other person that's really critical in Nav-CARE implementation in the community is the volunteer coordinator. So each organization that has a Nav-CARE program also has a coordinator who's responsible for these volunteers. And that coordinator really has two roles. One, of course, is to recruit, mentor, and support the volunteers. But the other, similar to what Prav mentioned, is to really make the program more visible in the community. So part of their role is to talk to all of the partners who might be interested in getting involved with NavCare and really helping them bring together sort of that idea of what's going on in that community and how can you participate in it. So, and then in a practical sense, in each organization, the steps of actually getting connected are sort of as follows. So somebody makes a referral to the NavCare program. That referral could come from a healthcare provider, it could come from a friend, it could be a self-referral. And then it really is the volunteer coordinator that makes that first reach out and contact. Because of course, it's really important to make sure that this is actually really a good candidate for a volunteer. So the coordinator makes the contact, they do an intake assessment, and then once it's deemed that this is a good person for NavCare services, and then they link the volunteer with the person in community. And it's really interesting. We've done a lot of research around this, but it's amazing how skilled these coordinators are in matching volunteers with persons in the community because it's essentially a relationally based model. So it's that idea of connecting people who will probably do well in relationship. Then the volunteer continues on with that relationship, meeting with them regularly on a schedule that is really agreed to by the client. They get to dictate the type of contact that they want. And then it goes on from there. There is ongoing mentorship and support for the volunteers through the volunteer coordinator. And the expectation always is that they would take part in that volunteer and support because we are asking a lot of them as volunteers. So it's really important that they stay engaged in the bigger organization.
Yeah, thank you for that. And I'm wondering then, would you be able to tell us a little bit more about the volunteer navigator role in terms of if they were meeting with that senior client in their home and kind of like on a long-term basis to help them, what would be some of the actual activities or things that they might do in their role to support them?
Yeah, so we really teach volunteers that the first part of that role is really all about relationship building. Even though that there's a navigation component to this relationship, what we found over time is that a degree of trust needs to develop between the volunteer and the client and a degree of familiarity often before the navigation functions come into play. And so part of that early relationship building is really getting to know that person, knowing their family, what's important to them, what has their life been like. So really, if you envision a cup of tea with a neighbor and really sort of getting to know someone. And then as the relationship develops over time, they begin to really probe around what are the quality of life issues that are most important to you. And that's going to be on a whole range. You know, that might be that people are experiencing grief. It might be that they're having difficulty getting around the community now. It might be that they're just feeling increasingly disengaged from community as they're experiencing some of the losses that come with chronic illness. And so then the role of the volunteer at that point in time is to come alongside that person, help them to identify what would be really important to them in terms of improving their quality of life, and then creating a very careful strategic plan in how you can do that. And I'll just give you one example. We had one client who had experienced significant loss in his life and had been a caregiver for so long and in such an isolated sense that he'd very much lost the sense of whether he was capable, for example, of returning into community and doing things the way that he used to. And so the volunteer role then became coming alongside, befriending, even playing games and make sure that he still felt that he had the capacity to be involved in the things he wanted to in the community, then helping to plan what would be important to him in terms of getting involved again in community, and then helping to put together all the pieces of how it is you get to where you want to go, and then supporting them as they go along that process. So that's just one example of what a volunteer might do in the context of that relationship.
Yeah, thank you for that. And what struck me is I heard in your response you saying the volunteer is going to look at what's important to the senior. And then Prab, you mentioned about what matters to you for when the connector's approaching them. So I see already some similarities in terms of that holistic, really person-centered approach. So that's great. And Prab, would you be able to provide a bit more details in terms of the community connector role? I know you've already touched on that they both help the senior, but they also have a capacity building role. And so could you tell us a little bit more about what the community connector would be doing?
Yeah, so for community connectors, the role does really have two key aspects. And the first is that obvious direct support to older adults. So they receive and manage referrals, they conduct those intake conversations, and like you mentioned, they use a what matters to you approach. And then they co-develop wellness plans with the older adults. They provide follow-up, check-in as needs changed. They help reduce barriers so that supports are not only available but also accessible. And this part of the role is very relational, grounded in trust, focused on empowering older adults to stay connected and to maintain their well-being. And then the second aspect is that relationship building, that network building aspect of the role. And this is foundational to the community connectors work. The community connectors will map local assets, they build partnerships across healthcare, social services, community organizations. They engage in communities of practice and peer learning, as well as sitting at collaborative tables within their communities. So they're constantly strengthening those referral pathways and advocating for more inclusive, age-friendly communities. This isn't separate from the individual work that they do. It's what makes that one-on-one support more possible and sustainable. So the role is always operating on two levels. And so, supporting those participants while also shaping and strengthening the community system around them. And like I said, both of those roles go hand in hand. And you know, what we have is our community collaboratives, and the CC sort of play a central role to those collaboratives. So connecting those senior serving organizations, municipalities, local healthcare staff, in sort of this collaborative approach to build those supports around seniors.
And I did see there was a question that had popped up in the chat about the community connectors and if it's a paid position. And so I'm wondering if you can speak to that, Prab, and then maybe afterwards, Barb, you could speak to for the volunteers. Are there any honorariums or support that's provided to them?
Yeah, I think that's uh the next part of what I wanted to touch on. So, for community connectors, um, their workload is balanced between those two roles. And then in terms of if we're talking about caseload, the recommendation we give is about 200 participants, but that isn't a hard rule. It definitely varies depending on the size of the community and geography. So maybe in smaller, more remote or rural communities, the caseload might be lower simply because there are fewer people. There might be longer travel times to get in touch with some of those older adults. In larger, more urban areas, a CC might have a higher caseload. But the goal is always to make sure that caseloads are realistic and allow connectors to provide meaningful support, not just transactions. The way time is spent also shifts. So in general, about half of a CC's work is is with the participants, meeting new participants, co-creating those wellness plans, checking in, following up. A little over a third might be spent on that relationship and network building aspect, like asset mapping, collaborating with partners, joining like seniors planning tables, for example. And then the smaller chunk of time goes to things like admin things, I guess you can say, like documentation. There's reporting that we collect, and then just things like professional development, training, communities of practice. Um, but again, that balance can look different depending on where the CCs are in their work. When they first start, a lot of time goes into that building trust in the community, mapping out those resources, developing those referral pathways. As those systems become stronger, more time shifts towards actually supporting those participants. But it's never static. The role kind of flexes to meet what the community needs at a given time. And yes, CCs are paid employees of those local agencies. And that's important because, the role demands sustained engagement, accountability for reporting, and long-term relationship building within the community. And this is, so that CCs can stay in place long enough to build the trust and the networks that may really make the social prescribing program effective.
Yeah, thank you for those clarifications. And then Barb, did you want to speak to the volunteer role and in terms of if
Yeah,
there's
so this is
ongoing or support?
yeah, this is probably one of the most significant differences between the community connector role and Nav-CARE is that Nav-CARE is built on volunteers. And so all of these people do this in a volunteer capacity, and they keep really small, I wouldn't even call them caseloads, they're one-on-one relationships. So a volunteer might have one client, they potentially might have two. And in some cases, we have had several volunteers for one client. And so where there is a particular high level of need and they want to share that across a number of volunteers. So it's a very small, very relationally based type of intervention. And they're not sort of a caseload where somebody comes off the Nav-CARE service at a particular time. And so they actually walk with these individuals over the journey, providing both are still available to stay within the relationship. Now, the person that should get some sort of pay is the volunteer coordinator, the person that oversees the Nav-CARE volunteers. But it is very much a volunteer-based model, and we always have been, and I suspect we always will be.
And I'd be interested to know, Barb, in terms of what training is being provided to the volunteers, because it does sound like they take on a lot in terms of supporting older people. And so what type of training would they need?
Oh, we're so proud of our training. This is something that we really have been working on very hard, actually, for over a decade. So Wendy Duggleby, who has been my partner in this work, at the time that we met almost a decade ago, she was working on developing competencies for volunteer navigators in rural areas. And it really has been her work that we've built upon over the last decade. So with each subsequent study, we have asked our volunteers to sort of fill out these self-perceived competency ratings. And so based upon that, we've really refined these competencies over time. And so with a really deep understanding of what does it take to do this role. And so competencies originally that they didn't seem to engage with, we would drop. If we would see that they were doing another more important role, we would add a competency. And so basically these volunteers, we ask that they already have some experience working with people living with declining health. Otherwise, I think it's a very difficult journey for them, given that this is a one-on-one, fairly intense relationship in which they travel with them over a fairly long period of time. So they need to have some maturity and some experience already with what it's like to live with grief and loss. And then we have anywhere from 6 to 8 hours of training. It depends on whether they take it online and how long it takes to do it. It's available free online in English and in French. And, in essence, they learn, what is this role, how to do it, how do you assess quality of life, and how do you do that in a way that's very natural? How do you understand quality of life from a person-centered perspective? They learn about how to identify resources in their community and most importantly, how to connect people to those resources. So, what are the kinds of access barriers that people experience? How do you help them to overcome those barriers? A really important module is on engagement, in understanding how people can tend to disengage from life over time when they experience loss. And what is it that you can do as a volunteer to help people stay engaged? There's a module on technology, and then one very specific to supporting our most recent module that we're really happy with, supporting persons and their care partners living with dementia. So people take that training. As I mentioned, we do have it online, both in English and in French. It's very interactive. And the creators of that are online here today, and I'm very grateful to them.
Great, thank you. And I see somebody put in the chat that the training's wonderful, so evidently people appreciate it. All right, Prav, would you be able to tell us a bit about the training for the community connectors, as I know you've done a lot of work on that?
Sure. First of all, I just want to second that comment in the chat. I had a chance to take the Nav-CARE training. It is amazing. And as for the community connectors, the CCs, there isn't a strict educational requirement per se, but the training is an essential part of setting CCs up for success. Community connectors need a strong understanding of the issues that older adults face. So, and they need familiarity with local resources, the ability to work in a relational community-based way. So we've developed, and this is a big project for me, was developing the training program. It's in two parts. Part one is modules on the social prescribing basics, the fundamentals of the CC role. It focuses on things like asset mapping, relationship building skills, what a wellness plan looks like, monitoring and evaluation, and some things like self-care as well. And then part two is additional training that reinforces these skills, and it gives connectors space to practice. That's not the only learning they do. The community connectors are expected to participate in communities of practice. So we have monthly regional communities of practice, as well as a provincial community of practice that includes almost 100 CCs now. That happens twice a year. They also use Healthy Aging Core as a hub for tools, peer learning. We post our orientation sessions and workshops there. And it's a place for really engaging discussion as well. And I'm really happy to say that the discussion section in that social prescribing group in Healthy Aging Core is amazing, lively, and it's a great space for peer sharing, peer learning. And then they also stay connected with their regional healthy aging specialists. They provide ongoing guidance and support, as well as a connection to me, so that there's an understanding of what social prescribing looks like across the province. So the idea isn't that training is something that you do once at the start. A really key kind of focus of our social prescribing program is continuous learning, adapting as the role and the community evolves, and as the social prescribing program evolves as well. We learn from our community connectors within their communities, and we facilitate learning amongst other community connectors across the province as well.
Yeah, thank you for that, Prav. And I think now that we've talked a little bit about training and who's in the positions actually providing the support, maybe we could talk now a little bit more about the people who actually are being supported through these programs. So Barb, I'm wondering, is Nav-CARE like exclusively supporting seniors? Do they support younger people as well? Could you tell us a little bit more about the profile or the type of people who might be supported and how they might get into the Nav-CARE program?
You bet. So Nav-CARE was really designed for an adult population, and probably more specifically for an older person population. Although we have had a number of our community organizations also say, excuse me, I'm struggling with a cold today. also say, you know what, there's all kinds of adults in our community, not older adults, that would also benefit from these services as well. So that really has been one of the adaptations of Nav-CARE. And we have tried to keep sort of the population as open as possible in terms of really it's a self identification of a person who would benefit from having a Nav-CARE volunteer. So those tend to be people who are feeling socially isolated, who are, of course, experiencing declining health. And often what comes with declining health is difficulty getting around, maybe sensory loss, where it's a little bit more difficult to access some of our technologies that require certain things. Um, Certainly anybody that's struggling with a lot of decisions. You know, we have so many different specialty branches within healthcare these days that people might come home with 4 to 5 different and antithetical recommendations about what they should be doing based upon their illness. So these volunteers are really great in terms of being listeners, of helping people to sort through their decisions. And so they're, you know, really the population that we're looking at in a nutshell is they're experiencing some sort of declining health that is now at the point where it's affecting their quality of life. And they could just really benefit from having another person come alongside them in community to really help offset some of those quality of life impairments.
Yeah, thank you for that. And I see that there's some potential overlaps, but also some potential, I think, differences then in terms of the people being supported through Nav-CARE and social prescribing. And Prab, you already mentioned about the priority populations that we focus on. And social prescribing for United Way is specifically for seniors. So I think we maybe see the difference there then. Maybe I can move on then to our last questioning because I want to make sure we have time for our other presenters. But I'm just wondering if both of you could tell a little bit more in terms of how long the people are being supported through the program. Is it a few months? Is it a year? Is it weeks? What would that normally look like in terms of a client? Or a senior being supported, sorry, not client.
Yeah, so maybe I'll start. You know what? It's a long-term relationship. And so in our ideal world, that this person will follow the person even through transition. So let's say that they begin the relationship in the home and that they eventually move to long-term care, that the volunteer would follow them into assisted living or long-term care. And actually in some cases they'll follow them through to death if that's part of their declining illness trajectory, and then work with the families into bereavement. And so, you know, I don't have stats really from our current sites, but from of our early study sites, that could mean a year, 2 years, or longer. Our goal really is this idea of a palliative approach to care. So when somebody has declining health, you get involved with them way early upstream to give them support as soon as they begin to experience those effects on their illness, and then you follow them down the journey or through the journey, however that goes. So it is definitely a long-term relationship.
Yeah, thank you. And then Prab, did you want to respond to that? And there's also been some questions about referrals as well. So maybe you could also just briefly speak about referrals for the social prescribing program.
Sure. Referrals come from a lot of different places. Healthcare providers are a major source, so that could be, family doctors, nurses, social workers, the home and community care staff. But they also come from community partners, local agencies, sometimes directly from the older adult themselves or their friends and families. And the key is that pathway is open. Um, and yeah, so that's basically it for the referrals. And so um, a typical visit and how frequent those are. So for community connectors, um, the visits are flexible and they're very person centered. So the first meeting usually will, take place in a comfortable environment. So that might be the participant's home, um, at their agency or somewhere neutral like a coffee shop. The focus is on, building trust, exploring strength, and again, asking what matters to them the most. So the conversation is hopefully led by the older adult. We don't want it to be like an interview or a formal intake. We just want it to be a conversation. And from there, the CCs work with the participant to co-create a wellness plan, and support them by putting that plan into action. That will include regular check-ins, maybe troubleshooting barriers. It might be a light touch follow-up to make sure things are working. Um, the intensity of visits might be higher at the beginning and then taper off intentionally. The aim is to create isn't to create sort of a dependency, but it's to kind of empower the older adults to build confidence and connection so that people can carry on accessing those supports independently. Typically, we sort of say the support lasts around 6 to 8 weeks. It can be shorter or longer depending on the person. Um, Social prescribing isn't, most importantly, a one-time opportunity. If new challenges or needs come up in the future, participants can sort of re-enter that social prescribing pathway and be connected with the CC again.
Right, thank you. Well, thank you both, Prab and Barb. I think that's hopefully given people a general overview of the programs. And so now we're going to move on to our two other presenters, Yola and Nicole, who I think are going to be able to give us a bit more of an on-the-ground picture of what these programs actually look like in practice. So I believe Yola was going to be the first to present, so I'll invite you to speak about your program.
Thanks so much, Laura, and thanks everyone for having me here today. Like Laura mentioned, I've been a community connector at North Shore Community Resources for about 3 years now. And at North Shore Community Resources, we have the Community Connector program and we don't have a Nav-CARE program. So the story I'll be sharing today is of a participant I've worked with through our Community Connector program, as an example of how it works. And the story is also an example of one of those deeper dive sort of cases, ones that we worked on several different things together over the course of 3 to 4 months. And like Prab mentioned, there can be cases where it's just one phone call or, a short period of time we're working together, or it can be these longer periods of time where we're doing more together. And that often does happen. But the one I'll be sharing today is that deeper dive where we spent more time together. So I'm going to be telling you about Peter. He was referred to the Community Connector program from one of our our internal programs. So some of our other programs, we have the Better at Home program. Um, and we had an initial meeting, which is usually the process. Usually I'll get the referral and then I'll call the participant, tell them a bit more about the program, get to know what they're looking for, and then we'll have an initial meeting, which is a bit of a longer meeting to understand their story, build some rapport, build a relationship, and understand what they're looking to do. And in Peter's case, this was a home visit. And I think that's a really great opportunity we have, is to do home visits. If we feel comfortable, I think it's really nice to go meet people where they're at, and it allows us to see people that might not be able to come to us. So yeah, in Peter's case, it was a home visit, and we identified the main goal for him, which was he wanted to attend some physical activity programs. He wanted to use the rec center pool and go to some other fitness classes. And he also wanted to do this as an opportunity to gain some social connections. But he had a few barriers, transportation and finances. So in terms of transportation, he had used HandyDart a little bit, but he had felt that it didn't provide quite enough flexibility for his circumstances. So he'd been taking taxis quite a lot, and that also wasn't working very well for him financially, but he was also having trouble just booking the taxis because the rec center was actually quite close to his home, and so often taxis wouldn't want to take him there because it was so close. Um, so he'd brought up Uber. He'd heard about Uber and he thought it might be a good option for him, both financially and flexibility wise. But he needed a smartphone to book the rides. So I was able to help him apply and get a free smartphone and a low-cost plan from one of the big providers that provide low-cost plans for older adults. And he was able to use it and to book a ride with Uber. So I also, another piece of this was that he was wanting to go to the rec center, and was having some financial barriers there as well. So I also helped him apply for a subsidized rec center pass, which allowed him to access those programs a lot easier. And he was also approved for that. So it was great news. A couple weeks ago, he was able to book his first ride and attend his first class, and it all went really well. Um, since this happened recently, I'll give you an idea of how the cases usually end, or how we close them. Um, in this case, we'll probably do a couple more follow-ups just to make sure everything's still going really smoothly, and that Uber is working for him, that the rec center pass is working. And then it will probably end in a fairly natural way. I usually put it in the participants court to reach out to me if they have any questions, or if something new comes up, they can reach out and we can work on that together. But that's generally how it goes. It's a more frequent contact for a period of time to meet these goals, and then it will be a couple check-ins, and then I'll leave it in their court and they can reach out to me if there's more. And this case was also, I feel like, a good example of a successful case that had some big changes for Peter, but I do want to mention that it's not always like this. Sometimes we have to take a lot smaller steps. So, for example, with someone else, they might need some tech classes first to learn how to use the smartphone. So that might take some more time. Or sometimes the transportation or financial barriers are just so large that it's hard to do the things that they want to do. But we always try to at least take some small steps with people and try to explore as many options as possible so that they can access some additional supports and improve their quality of life. But I wanted to share this story because I thought it was a good example of how the program can work and how it can be really helpful. And yeah, thank you so much for having me here. And I think I'm going to pass it to Nicole.
All right, thank you so much. And Nicole, I think you can now speak, and you have both the Nav-CARE and Community Connector program at Brella, so you can speak to that. Thank you.
Yeah, thank you, everyone. Yes, we are lucky enough to have both programs. So I'm going to do a quick share screen here so that everyone can see my slide. There we go. So this is kind of an amalgam of a typical client that we would see. We have Bob, he's 84. He lives alone. He's been recently diagnosed with dementia. He has a son, but he doesn't like to rely too much on him. He's lonely and he's worried about his prognosis. He recognizes now that he's not eating properly and he forgets sometimes to take his medication, and he's recently lost his driver's license. So the first thing we'd want to do is get him through the process, as we've talked about, getting a one-on-one session set up with a community connector so they can identify both some short-term and some long-term goals. So an easy way to think about how we've chosen to divide up the duties is that often our social prescribing team will deal more with the short-term goals, and we'll work with the Nav-CARE volunteer to deal with some of the longer term goals. It's not always absolute, but that's kind of a helpful way to think about it. So in the short term, Bob has identified that he's not eating properly. So our social prescribing team would want to get him connected either with Meals on Wheels, frozen meal delivery, maybe if there's some help getting some grocery shopping. He's not taking his medication, so we could get him connected with Home Health or HealthLink, or there are some pharmacies that'll do reminder phone calls. And because he's lost his driver's license, they would help him fill out the HandyDart application and get that submitted online. In terms of some longer term goals that the Nav-CARE volunteer can work with, because of course they have more time and a longer window to be able to see Bob. So because he's concerned about his diagnosis, we'd like to get him connected with our dementia support group. We have one that meets here weekly for individuals with cognitive decline and their carers, and it gives them a chance to really connect with people on a similar journey. We'd identify and help him participate in some social activities. So they might even attend with him at first. So if there are meal programs or dropping coffee times or whatever, they could help him get connected with that and go with them a few times so that he feels comfortable. In terms of transportation, the Nav-CARE volunteer would help him learn about some of the transit options, right? How to use HandyDart, how to book a ride, and they may, even go with him on the bus a few times so he gets familiar with how that works. And then, finally, in terms of meal prep, they can do a little bit of meal prep together. They'll also do things like monitor his fridge. Does he have groceries? Is the food spoiled? Things like that. So they'll kind of keep an eye that way. And throughout this whole process, one of the best parts we found is that the Nav-CARE volunteer is coordinating with our social prescribing team. So if there's an issue, a new issue that comes back, they can refer him back to the program for help with that, particularly for things that may be, beyond the scope of the Nav-CARE program. And then of course the social prescriber will send things back to the volunteer as well, if there are recommendations for different things that they could do with Bob. So that's a little bit of an example of how we connect the two programs. And with that, I'll turn it back over to Laura.
All right, well, thank you very much for providing that example of how the two programs can complement each other and work in partnership. I think that's really great to be able to see. I see we have a very active chat going on, so that's great to see that so many people have so many comments, questions, ideas about the two different programs. So thank you for everyone who's been putting in comments. We do have about 10 minutes left for questions, so I'd be happy to see if there's any questions we want to take. I think there's Q&A box, and most of those questions have already been answered actually by people typing answers. So I'll go to the chat and see if there's any questions there that should be answered. And I'd like to invite all the presenters if you'd like to come back, and then we can see what questions we have and who would be the best to answer them. All right, so I see there's various comments and questions, just like asking for a little bit more detail, trying to work out what the differences are in terms of the Community Connector and the Nav-CARE program. So maybe I can summarize some of the key things that I've heard so far in this webinar, and then I'd like to invite the presenters if you have any additional thoughts that you'd like to add in. So obviously in terms of Nav-CARE and social prescribing, there's different origins, with the Nav-CARE program coming from work that was done in Europe and with the University of Alberta, and then social prescribing has origins more from the UK actually. And then they serve some different clientele currently. So it sounds like social prescribing is focusing exclusively on seniors, while the Nav-CARE program is looking at a broader range of adults, often with some health condition or life-limiting illness. We also heard about the difference in terms of the people who are providing the support. So with Nav-CARE, they have a volunteer coordinator, and they have the volunteers themselves, though, who are actually doing the bulk of the actual providing of support. While with the social prescribing program, we have the community connector role, who is doing that role of assessing the person and then actually providing the support and referrals. We also heard about the differences in terms of I guess, scale, in that the Nav-CARE volunteers are often going to be working with one individual, potentially over a fairly long term, perhaps over a long span of their life and perhaps even until they pass away. So that could be potentially a relationship that's a year or 2 years. And the community connectors, on the other hand, we heard have a larger caseload. So they might be helping maybe 40, 50, 100 people on their caseload. Obviously, not maybe all at the same time, but they're going to be helping a larger quantity of people. And in many cases, that relationship might be more time limited, where perhaps it's a few months they're helping the person for, and then the person transitions out of the program. So those are some of the key differences that I've heard, but I'm wondering if any of the presenters would like to chime in to provide any other comments about what they see as those differences between the programs, and then also about how they see the two programs as complementing each other, which I think we heard a bit about from Nicole, but I'd love to hear any other thoughts about that.
Yeah, I'll begin because I think the one thing that's really enamored me about Nav-CARE over a long period of time is just how powerful volunteers are. And the thing is, and I think that's probably why we situated the program within a volunteer model, because volunteers traditionally in hospice have assumed sort of this in-between space between family and people that get paid. And so, and volunteers have, I remember a client said to us once, you know, somebody that gets paid actually has to be with me. My family have to be with me because that's expected. The volunteer comes because they want to be with me. And I mean, that could certainly be a part of the social connectors model as well, because it's deeply relationally based. But I do think there is something very powerful about the existence of volunteering in Canada. And the thing that our studies have shown over and over again is that the relationship is as powerful and as rewarding for the volunteer as it is often for the client receiving services. So I really just love both the role that volunteer agencies play on the Canadian landscape and really the role that volunteers play and what a meaningful role it can be, especially after people retire out of healthcare related roles. So I love that. I see actually an incredible amount of synergy between these two programs. I think if we were to put them together, the power would be dynamic, because not only do you have, you know, now a paid position in Canadian healthcare of somebody that does that initial sort of connecting and helping people as they come out of, but now you have this whole volunteer workforce who are passionate about what they do, who can broaden that influence along with the community connectors. So, you know, I think we've stumbled a bit because these two programs came up together in Canada from different routes, but I think inherently they are a perfect match, and I would love to see them go forward together.
And thank you for that, Barb. That kind of, you know, summarizes exactly how I feel. And Laura, I think you provided a great summary of the two programs and how they can support each other. But I just want to emphasize that I don't think it's about overlap in the roles. I feel like it's about layering the supports for older adults. The CCs might focus on pathway systems, you know, structured follow-up, while Nav-CARE navigators provide that ongoing relational presence. I feel like together, both of these two programs create a stronger web of support for older adults.
I feel too like the Nav-CARE program gives a depth and a reach to social prescribing that it wouldn't otherwise have, right? You can't go and take a bus with a client. You can't build that really deep or long-term relationship with a client as a community connector. So there's this really beautiful depth and reach that comes about when you have the right volunteer pairing, because they will get places that a paid role can never get.
Yeah, I want to thank you all for those comments. I think that's really useful in terms of elucidating how the programs can complement each other. And it definitely is great that there's opportunities for them to work hand in hand, like at Brella. I do see there's a number of different questions on the chat. I know we only have a few minutes left. So I'm going to suggest that maybe some of the questions are fairly specific and others are asking for things like resources, trainings, that sort of thing. So maybe what I can do is after the webinar, I can go through the questions, and I think a lot of them might be able to be answered by very short kind of responses, links to trainings, that sort of thing. And when we send out the webinar recording, we could send out the answers to some of these questions that it seems like it'd be useful to provide answers to. Does that sound okay to folks? Yeah. Okay, so folks in the chat, if you do have questions, we'll try and get them answered if they haven't been already, and we'll try and pass on resources like the training materials, because people seem very interested in terms of if they can access Nav-CARE and Community Connector training, so we're happy to pass those on. So in that case, as we have 1 minute left, I would just like to invite any of the presenters, if you would like to have any final thoughts on Nav-CARE or community connectors or anything in general related to the webinar.
I just want to reiterate my thanks, Laura, for the sponsorship for this today and for the ability to, just speak with this group of people. Thank you for coming today. And I'll pass it to Prab.
Mute button was missing. Sorry. Yeah, same thing. I share the same feelings, Barb. This gets me excited to see the future of these two programs working together. I know there's incredible examples already within the province, like like you mentioned, Nicole, of how we can, support each other's work. And I think, this very intentional conversation and discussion is just going to support that and hopefully help other communities do the same.
And thank you everyone. And thanks to the Nav-CARE team for really bringing this amazing program to the forefront, because there's amazing synergy in the way that these two programs can interconnect.
Yeah, and I'll just briefly add that I think because our organization doesn't have Nav-CARE, I can totally see that need and see how Nav-CARE could be so amazing for providing that more long-term relational support. So I hope it grows and that we can work together.
All right, great. Well, I'd like to thank our wonderful presenters. I feel like I've learned so much today about the Nav-CARE program and also the social prescribing programs and what they're about and also how they can complement each other. So I'm really excited that we've had the opportunity to have this conversation. As I've mentioned previously, we will send out the webinar recording for those of you who'd like to look at it again or share it with others. We'll also share out the answers to any questions in the chat that it seems like still need to be answered, or if there's links that we can provide, we'll definitely do that. And if it's okay with you, Barb and Prab, I'll provide your email addresses as well, so then if people want to know some more specifics about the two different programs, they can get in contact with you for questions. All right, and in that case, we are only 2 minutes over, so I've done an okay job keeping us on track. And I hope that everyone has a really lovely rest of the week. I guess we only have 1 day left. And I did mention at the beginning, of course, that I was going to share some resources related to Truth and Reconciliation Day, which I didn't have time to put in the chat, but I will send them out in the follow-up email. So everyone have a wonderful rest of your week and take care.